I'm Kurt DeVine, Heather Bell. Everybody should kind of know who we are at the moment. So, again, announcements. Remember, these are recorded. We'd love for people to have on their video, but if you don't feel comfortable, that's fine as well, but always makes it more fun for us.
And then just let us know if you would like this recording, or if someone you want, or someone else wants to see these, or if you can't make it in the future, we can definitely get you those recordings.
Yeah, and remember, there is free CME, but you do have to fill out the thing that they send. So make sure that you're watching your email so that you get your credit. And again, if there's more than one person in your room, please just let us know and rename yourself, and just so that we know who's on. Again, feel free to turn on your video. Case presentations, we're happy to do case presentations at any time. So if there's a case that you want to discuss, that would be great. Anytime that you have that, we'd love to help you. Upcoming Tuesday sessions, actually next week.
2 weeks.
2 weeks. Heather's going to be doing the infectious disease complications. That's actually a really pretty interesting talk. And then, of course, we move through the other ones: emergency departments, benzos, and alcohol. So lots of fun topics coming up. Again, this Wednesday, we got Dr. Charles Resnikoff coming back again to finish up his fentanyl test strip talk. It was so good last time, so we're pretty happy to have him back tomorrow. And then next week, Amanda Noska with the part 2 of her HIV talk, which is also great. So feel free to come back for that. Remember, our podcast, actually, it just released today, a new one. It's on kind of the legislation over the last 50 years that has impacted addiction. It's kind of interesting. If you don't know some of these things, I think you'd find that pretty helpful to give you some background. It's
because heroin was the first MAT. Yeah,
heroin was like MAT for morphine back then. So it's kind of a fun talk. And again, anything that you need help with, please write down our cell phone numbers. We're happy to help you if you have questions with the patient or concerns. So feel free to give us a ring. Those are not the actual objectives today. So I'll just kind of tell you today what we're going to do is we're going to go through just fairly briefly. We're going to talk a little bit about that intake and those first patients that you see. And then we're going to kind of run through the 3 different ways that people can do inductions, both the normal induction, what we consider a micro induction, and now what we call a macro induction. And so it's something that you have to think about as you're seeing patients, so that you kind of know which route you want to go. So let's talk a little bit about the intakes. And I think often when we see patients, there's just these important questions that you kind of need to know. And I think one of the things we want to do is make sure that patients really get taken care of as close to their home as they can be. So really where they live is important. Often they'll find you and maybe there's somebody closer to their home or somewhere. Often transportation is a real issue for patients. And so again, where they live, who their usual physicians are really important. We like to know too, if they're changing providers, what's the reason? Were they having problems with somebody else that was giving them buprenorphine? And if they were previously seen by somebody, what was their experience? And clearly in these issues, and I think we're really with any patients, we always want to get their records. So I think that getting those records after you've seen a patient the first time often can give you a lot of great information. And really, current medications. I mean, sometimes patients will show up and they're on Suboxone, or they're using heroin, and they're also on benzodiazepines. They're on stimulants. Are they taking methadone? Occasionally we'll have patients who are taking methadone come in, and they may want to be switched over to Suboxone. And so there's lots of different things and information that we're going to want as these patients present. I think the big question always when we see a patient for addiction is really what's their drug of choice. And often it's not obvious. We have patients that come in requesting to go on Suboxone, and in fact, they don't use opioids. They may think that Suboxone is also useful when we treat things such as methamphetamine use or other different things that they might be using. So getting ER records sometimes can also be helpful when they've shown up and they've had previous urine drug screens. We want to make sure that if we're putting somebody on Suboxone, that in fact their issue is opioids, and sometimes that's not clear. So in our clinic, the way we would typically run things is we have a lot of different forms and a lot of information that we like to give actually before we see the patient. And so often we'll Did we already get that? Yep. So often we will look through that information actually before we see the patient. And that really helps us tell whether or not this is a patient that's appropriate for Suboxone. If not so, sometimes they're appropriate for other treatments, depending on what things they might be using. And what if they're in withdrawal? What if they're clearly in withdrawal? If we have a patient that's very clearly in withdrawal, we want to see that patient and take care of that patient as quickly as we can. And so that's not somebody that we're going to say, oh, we'll get all our information today, and what we'll do is we'll bring you back tomorrow and we'll start you. If we do that, we're going to have a patient that does not show up again. So when they're in withdrawal, that's a patient that we want to make sure that we take care of right away. And patients really come into our clinics in a couple different ways. They can come into our clinic very obviously in withdrawal, very appropriate for Suboxone. And we want to move that patient into the medication part of our visit relatively quickly. And often all the things that you see on this list of consents and urine drug screens and all this, there's a lot to do in a first visit, but we may not do that right away. We'll do the things that we have to do right away to start the patient on the buprenorphine. And really the biggest thing is get a urine and make sure that they sign a consent form to be on buprenorphine. And then a lot of the other things we can do later. And so as we look at the list of things that we've got to do, just remember that that patient is feeling ill. And the sooner that we make them feel better, the better information, honestly, that we get, and the easier it is to go through some of the forms and other things that we're going to need to do. Sometimes we get patients that come in very clearly on their urine drug screens and very clearly in their history. They have a history of opioid use disorder, but they're not sick enough. And so often that we have to look at this situation, we have a couple different ways we can go. We can get all the information today. We can fill out all the forms, have them talk to our social worker, make sure that the medication is at the pharmacy, and we can really decide whether we want to bring them back the following day for an induction, or we'll talk about in a moment, do we trust them enough? Are they somebody that's experienced enough that we can send them home and do a home induction, depending on exactly what we're finding in the urine screen. So when we see a patient initially, there's a lot of different things that we're looking at. And frequently these are patients that are not healthy. They have a lot of medical issues. And when they're withdrawing, they will have lots of irritability, and they'll be very somewhat difficult sometimes to deal with the nurse. But they'll have very obvious things. They'll have the large pupils. They'll be sweaty. They'll have signs that they were actually injecting. But we have to look for the other things that would tell us that there might be bigger problems. And I think probably the biggest part of that is really listening to their heart, listening to their lungs. A patient who has IV drug use, who has a murmur, that's a whole different situation. It's something that has to be looked at very quickly. They may have more than one substance use disorder. And so we might be checking for their liver edge. We might be looking for other signs of different substances that potentially the patient has been misusing. But again, teeth, sweating, signs of infection anywhere. I think that those are things that are very important. Do they have a fever? How ill do they really look? I've had a patient that came in, ended up having an empyema and was sick and was withdrawing, and really could have been easy just to start them on the buprenorphine and let them go, but they can have other issues at the same time. So we really need to do a pretty good evaluation of their blood work as well. And I think that these things are kind of the minimum. We always want to do STI screening. We always want to be screening for hepatitis C, which is relatively common, especially if they're using IV, but they don't necessarily have to be using IV to get hepatitis C. Hepatitis C can be spread even through some of the devices they use to smoke some of these things with. So it's important to not say, oh, they don't use IV drugs. We don't need to do this and this and this. HIV, again, relatively prevalent as well. But when we're looking at the female population, especially in this group, we want to absolutely be sure that group is not pregnant. And if they are, again, as we'll talk about in a few minutes, that may change a little bit about how we approach them for an induction. So lots of different things blood work wise that we can do just to get an idea of where we're at with this patient. Now, in the old days being a couple of years ago, we had a lot of issues with prior authorization. Now we have more problems really with getting dosing correct. And if you put a particular dose, or if you do it too many times a day, suddenly the insurance companies will reject your requests. There are still occasional insurance companies that will ask for a lot of information to get the patient started on, but most of those barriers over the last couple of years have been removed. And so this is, in general, a historical slide. But when we need a patient to be started on buprenorphine and we need to induce them, we need to be flexible. Again, it's so important that we get these patients in when they're having the problem, because if we wait, they will go use, and then we won't have that chance to get to that patient potentially for months or maybe never. And so often in our career, I mean, we have sometimes just had these patients come in right now. If you're in withdrawal, come now, and we'll squeeze you in and we'll make it work. And the big question is, well, what if they aren't that sick? When are they going to withdraw? And I think often we can surmise when they're going to withdraw, but I think that often if you just ask the patient, when typically do they start having symptoms, that's much easier because they know when they need to use next or they're going to be quite ill. But in general, if we're looking at short acting, it might be as early as 12 or 14 hours. If it's long acting, it can be as early as a day and a half. So really can change. But again, the patient is going to be able to give you that information. So it's very scientific. You just, when you're going to get sick, let's get you back in here. Now, the question really nowadays is, do we do this in a clinic or do we do it at home? I can tell you I have friends who do addiction who have had some bad experiences doing home inductions. I think most people have done it for a while, have run into that. In my opinion, it's a lot easier to do a home induction than somebody who's been on buprenorphine before. They understand the medication. They follow your suggestions much better. But it can be done both ways. And in fact, a lot of the studies show that home inductions can actually be done with some safety and probably no increased risk of doing it in your clinic. But I think the important thing is when you see a patient is when you give them in the instructions, they can't look like this up on the slide. If your handwriting is that bad, you need to put it in print and explain to them exactly how they're going to take the medication. And I think the biggest problem really with this has always been patients tend to take it into their own hands and they start taking medications the way they think it should be taken. So you need to have that conversation with the patient that they need to really follow the rules. And if they don't think it's working, they need to call. That's really an important point because often these patients are a bit of a pharmacist themselves and they'll kind of figure that they can kind of wing it. We like to do the in-clinic inductions, and I think the biggest reason for that is that it really gives you some time to kind of get to know the patient. The nurse can go in there frequently. If you have a social worker, they can pop in and talk to the patient. It's really, I think, one of the most impressive things for staff to see when a patient comes in withdrawing from an opioid and they look horrible and terrible, and they've really just have difficulty getting in there. And an hour later, they look great and they feel great and they want some food and they feel better. And it just has always seemed to us that when we have done the inductions in the clinic, that these patients are often kind of imprinted on us and they just become our best friends and they're just happy to see you every time they see you. So I think most of the time I've still done in-clinic inductions just because I think it's just that time where you get to spend a little bit of time with the patient going back and forth in and out of the room as they get better. And so now we're going to talk a little bit about the COW score. And of course, the COW is the clinical opioid withdrawal score. And I think that's really how we're going to decide when we're going to dose a person. Okay. So this is we're going to talk a little bit first about a traditional induction. So what we would consider in the old days, kind of the way it was always done. And what we look at with the clinical opioid withdrawal score is really getting patients relatively sick. And the score that typically we get is around 12. Now, as most of you, if you've looked at the COW scoring, it takes into account a lot of different things, whether they're sweaty, whether they're agitated, how they feel. And just remember that a lot of the scoring of the COW score is actually subjective. Okay, so the patient has to tell you how do they feel. And remember that there's a couple things that you look at that tell you how it's going. And really the biggest one is their pupils. And so always be looking at a patient's pupils. If they have very tiny pupils, and I have had people come in for inductions and kind of pretending to be sick, but their pupils were pinpoint. And so that's not a patient that you really are ready to do the induction on, at least not a traditional induction. So remember that the pupils, you cannot fake that. And I think that that's really important to kind of watch. And if they're sweaty, they're sweaty. They can't fake that. If you go in there and they're dripping sweat and their pupils are huge, you're in the right place at the right time. So in most of the training guidelines, if you've taken the course, it talks about giving that 2 to 4 milligram dose of the buprenorphine and waiting a couple of hours. I think in our practice, we would move a little bit more quickly than that, typically give them a couple milligrams and then just maybe 30 or 40 minutes at the most, and then redosing them. And this is with the classic opioids, okay, and opiates, things like morphine, things like heroin, and we'll talk about this in a minute, different things that they could be using that are not as high activating and potent as things like fentanyl or methadone. And I would tell you that often we would get up to 10 or 12 milligrams relatively quickly. So this would be a traditional thing. And again, a lot of times, how do we tell if they're getting better? Well, they start to get a little bit hungry, they get a little tired, they may want to lay down. But when they're ready to go, we need to then write them instructions about what we're going to do over that next day or two. If you're planning on seeing them the next morning, which I think we were more likely to do early on when we started using buprenorphine, you're going to want to write out exactly what they're going to take the rest of the day. Now, according to the kind of the guidelines in the training, 12 was kind of the top milligram that you'd go to in a day. And I think often we would go above that, but sometimes you do and sometimes you don't. And so, we would every patient's different. And I think it's just important for you to understand, just see what their response is to the first doses as to whether or not you're going to need to dose them later in the day or overnight. And in the real world, things are different. If you look at the difference between people who are just using pills, maybe oxycodone pills, versus people using IV heroin, the amount of the medication they might need to kind of pull them out of their withdrawal might be significantly different. And especially if we look at things like methadone and fentanyl, which we're going to talk about separately, because those can really affect the decisions that you make. But there is a big difference. If you got somebody that's in withdrawal from, taking 3 oxycodone or 6 oxycodone a day, it's much different than if you have somebody using 2 grams of heroin a day. And so the dosing may be significantly different. Now, early follow-up, I don't think is a bad thing. I think, especially early on, if you're just starting to do this type of work, I think it's probably a great idea. Again, this is a patient group that sometimes has difficulty with transportation, and so that may be an issue. I would tell you that in my experience, and I think Dr. Bell would probably say the same thing, getting these patients in early the next morning is always going to be tough. They're not going to get up early the next morning. And so I often would set their appointments up for later in the morning or early afternoon if I'm going to follow them up the next day. They felt pretty terrible. And a lot of times when they go home, they're going to sleep and they're not going to get up very early to see you. So I think a lot of times it's appropriate to do a phone consultation with them that next day, or a telemed. You can do a telemed visit, recheck with them, and then if you need to adjust their dosing then. And one of the things you're looking for with that early follow-up is did they take the meds like you asked them to, right? And at that point, you can sit down and really set up how you think their dosing is going to go for the next week, and then kind of look at follow-up for a week or 10 days down the road. I think once patients feel better, they're much more likely to want to have a conversation with you. They're not super chatty when they're in withdrawal, so you're not going to get all of the story. And I think that when they're feeling better, it's just a much nicer conversation. And if they come back the next day, often you'll have a lot of their lab work, and there can be things on there that may need to be discussed. But a lot of times the things, especially the HIV and the hepatitis C, those aren't going to be back until they're back in a week. So I think that first follow-up can be a little bit later, but again, telephone follow-up I think is always a great idea. And what's really important in a follow-up visit? Well, let's say you're a week or 2 out. Let's say you're a month or 2 out. What kind of things are going to be important to when you see this patient that you want to be able to notice? And I think for me, always the number one thing that I'm looking at is their weight. And because in almost every case, patients who've been using IV, either heroin or fentanyl or even methamphetamine, it doesn't matter what they're using. These patients often weren't eating and they had very poor nutrition. And I want to see that they're gaining weight. And in fact, if they're losing weight a couple months down the road, I'm worried and I'm asking more questions. And so just keep that in mind, that weight is one of those things that you want to just really keep an eye on. You like to see them put on 10 or 15 or 20 pounds over the first couple of months. And I would say frequently they do. Obviously, if they have new injection sites, that's an issue. Sometimes you see patients who are smoking different substances. They may come in and they may be coughing or acting like they're having trouble that way. Clearly, if they're tachycardic, that catches our attention. But I think far and away, the vital that I look at the most is the weight. Sometimes you'll see other things. I think that, just their general demeanor, and have they been showering again? Have they been doing those things? I mean, you might see a whole different person when they come back. And I think that's really the excitement part of this job, is when they come back a week or two later and they look like a totally different person. So I think that's one of those things that we look forward to. So what kind of problems can we have? Well, one of the things that you'll see is if patients early on will come in and they might be taking, 12 or 16 milligrams a day, and they'll say they're still having cravings. And in fact, they might even say, I'm having using dreams. And if they're having using dreams or cravings, that's an indication to us that we're probably going to need to bump their dose up a little bit. You may not have to dose it a lot higher, but you might go up 2 or 4 milligrams to kind of get those symptoms to go away. These using dreams are very difficult on people, and you don't want them having too many of those. They can seem completely real, and these patients will wake up thinking that they just used heroin, and they'll feel like it. So that's a reason that you want to kind of do something and get their medication level up a little bit. Some of the triggers that they'll have may be related to patient or other people that they know that they're running into. It could be something as simple as a car that looks like their dealer's car. And so, ask them these questions. Are there things that are bugging them? One of the interesting things we've seen over the years is that often we'll see people, whether they're a pill-taking patient or whether they're an IV person, or no matter how they're using the substance, they might be doing it a lot of times a day. They might be doing it 4 or 5 times a day. And when they come in and they're just taking Suboxone twice a day, they will get very anxious about that. And so it's not unusual that for the short term, we'll say it's okay to cut them and take it 4 times a day just so that they have something to do. I've had patients who would snort heroin and could not get out of the habit of snorting heroin. And my patient came in and he was snorting ibuprofen every day because he felt like he had to snort something. And so it takes a while to get these patients out of these things. And remember that a certain amount of this is compulsive, and they get in this kind of this groove, and it's very difficult sometimes to get them out. So just remember, and emphasize too, that the patient needs to call you. If they're having a problem, call your nurse and do what you can to help them. And remember that they need to be reminded frequently that they don't increase their own dose, that we really want to talk to them. Again, a lot of these patients are part pharmacists, and they will start to adjust the medication as they see fit. And you just got to make sure that they understand that we really kind of frown on that. I never lose my cool, but I just say, hey man, you got to let us do that. Please just at least call and have a conversation with us, because often patients are taking extra doses because they notice it helps their anxiety. So they get anxious, they take extra. They have a bad day, they take extra. And we want to really ask why we're doing that and address that problem. So does normal dosing work for everyone? Well, it depends on who the patient is and what the patient's taking, okay? And so we're going to talk a little bit about microdosing and macrodosing, because I can just tell you there are not great studies on any of this. And so all of us out here doing buprenorphine basically pick and choose how we're going to treat or dose each patient. And you need to be aware of some of the different studies that have been done, which are very few, when you're seeing these patients and trying to decide how to manage them. So this was actually a talk I did that had a Star Wars theme, and because we had to take out the Star Wars pictures in case they were a copyright issue. So we have gotten other Star Wars pictures, and they look a lot like Dr. Bell's children. So again, remember that when we're doing inductions on patients, adventure, excitement, a Jedi craves not these things, and I guarantee you, none of us wants to have a precipitated withdrawal. It is the thing you don't want to. I've been through it. It was very, not personally, I've been through with a patient, and it was very uncomfortable for me as well. So let's talk about why people do microinductions, which is honestly the way I do most of my inductions now. Not all, but most. And I'll tell you why shortly. So why is microinduction a thing? Well, the normal induction was the thing for the longest time before fentanyl showed up. And fentanyl's different, and methadone is different. And we knew years ago that when we would switch people from methadone to buprenorphine, that that's kind of a tricky switch because methadone is so long acting and some of the other issues with it. And when fentanyl came around, actually the first time that microinduction actually hit the internet and any of the different case reports was really when the guy suggested that you could switch people from methadone by using very tiny doses and increasing slowly over time. And we called that the Bernice method. And we'll kind of explain when we're going to think about, or at least when I think about doing a microinduction. This is a urine from a patient that I saw. And as you can see, there's nothing in it. Okay, there's no opiate. So, what would trigger opiate? Heroin would trigger opiate because heroin turns into morphine, and morphine triggers opiate, as does codeine. And so we've got this patient now who appears to be in withdrawal, and unfortunately, they have nothing in their urine that tells us what they're taking. Now, our assumption has to be it's the dark side. It is fentanyl, and so this is when we have to think differently. So let's just kind of set up what happens for patients that end up in a precipitated withdrawal, and how are you, by prescribing a certain way, potentially going to cause that? Well, the setup really is that first off, you have to have a long-term exposure with an opioid, and they have to be tolerant to it. So a patient has to have developed tolerance. So any opioid or opiate, any of them can cause a precipitated withdrawal if they've been on it a long time and developed significant tolerance, okay? And typically it's worse if it's a potent opioid. So when we look at things, even oxycodone is much worse, fentanyl, methadone. And typically it's worse if we get some of these different medications who are highly activating. And by activating, I mean, and I'm going to use my little thing that I say that Heather, I'm not sure she really enjoys this, but imagine that the drug goes on the mu receptor, and as it attaches to the mu receptor, it's going to activate at a certain degree. Kind of like if I had a mu receptor and I had a AA battery that sat on that mu receptor, it's not going to charge it up too much. But if I have a car battery that lands on that mu receptor, I'm going to activate that receptor a lot more. And so that car battery would be fentanyl, okay? It's just much more activating. And so if you remove it from that mu receptor is going to be missing a lot of activation, a lot of charge, okay? Now let's look at some of the different drugs that are the biggest problem. Methadone would be one of those. It's got a very long half-life, remember, and it's very strongly attached to the mu receptor. That's the other thing that really matters in an induction. How strongly does that opioid attach to that mu receptor? Methadone, it's fairly strong. Although interestingly, even at a fairly high dose of methadone, it may only cover half of the mu receptors, but it attaches pretty strongly. It has very high activation. So now we've got methadone. It really likes to stick to the mu receptor, and it really activates it. It's a car battery, okay? The one that's the car battery is fentanyl. This thing is not a small little AA battery. This thing really activates the mu receptor, and it is, again, it can be really a problem. It is very potent, remember. And one of the things about fentanyl that's different than the other opioids that we talk about is how lipophilic it is. So we will see people take fentanyl every day for a month, and they will collect a lot of fentanyl in the fat cells. And so even when they stop fentanyl, they will still have fentanyl positive urine for many days. And I've seen it as far as 5 or 6 days where they're still positive. So part of the issue with fentanyl is it is also extremely activating. So it is also the car battery. So imagine, if you will, that we also have another medication. We have our medication, buprenorphine, that's in our hand. And buprenorphine is the strongest as far as sticking to the mu receptor. It has the strongest affinity. It will push other things off that mu receptor. So it can displace fentanyl. It can displace methadone. It can do things that we wish it didn't do. But it also is not highly activating. So just in your mind, think about our friend buprenorphine coming along, and it's a AA battery, and it pushes off that fentanyl, which is a car battery, and suddenly the mu receptor has much less activation. And what that does to the patient is puts them in withdrawal. They feel sick, okay? And so that's always been the issue with buprenorphine, why you can't give it to somebody who's currently using and not in withdrawal. And we'll explain that, because the results of giving somebody buprenorphine who's just a big dose of buprenorphine with somebody who's using consistently every day, you're going to get that explosion you see here. So how can we avoid it? So let's talk about how we want to avoid causing a precipitated withdrawal. It's about science. And I think that we need to think about this in just a very simple scientific way. Remember that the normal induction worked best when we have these short-acting opioids. That was the old days with heroin and oxycodone. And again, they were not highly activating. And so in those cases, that drug would often wash out fairly quickly, and the patient wouldn't have any drug in their system within 10 or 12 hours. And so we could give them that buprenorphine and do very well with it, because we weren't pushing any drug off the mu receptors. It just worked better. It was a great time in our life when there was no fentanyl and methadone. So this is what a normal induction looks like. So these are schematics that I think Dr. Bell actually made, very fancy. So if we look on the left, these are the mu receptors that you would find in somebody's body when they're in withdrawal and they were taking hydrocodone, they were taking 6 or 8 of them a day, and now they're in withdrawal symptoms. The mu receptors are empty, the person's sick. I give them buprenorphine, which is on the right, and it attaches to those mu receptors, and it's not real activating, but I give them a big enough dose that it activates a lot of mu receptors, maybe 60 or 70%, and this patient has no symptoms and they feel great. And this is what we wish our life was like. But what happens in precipitated withdrawal? Now, if you look to the left, you can see that there's all these little 5-sided things sitting in those mu receptors, and all the mu receptors are full. And we're going to pretend that that's fentanyl. This person has been using IV fentanyl, and all their mu receptors are filled with fentanyl. And you can see the little things floating above it. That's buprenorphine that I just gave that patient. And well, that buprenorphine can push fentanyl right off that mu receptor, and so it does. And as it pushes all that fentanyl off those mu receptors, that patient is vomiting, sweating, tachycardic in about 5 minutes, and they are violently ill. So what you've done, giving somebody, and actually I've seen a case where somebody was taking methadone and did not tell the provider and did this exact thing and got violently ill and ended up intubated. Very nasty case. He did well though. So the science, again, a highly activating drug with less affinity to that mu receptor is pushed off, and now we got symptoms. It's very simple, okay? So remember that the microdose method of bridging is, the whole theory is we gently add the buprenorphine. So very tiny doses, because we don't want to push off the fentanyl too fast. We don't want to push off the methadone too fast. And so we give them this very tiny doses and slowly shift it. And with time, the patient metabolizes the fentanyl, and it goes, and they get rid of it either way, but it's going to take a little time, and we don't want them to get violently ill. So we slowly titrate it. So this is the depiction of that. So again, I got somebody who's withdrawing from fentanyl, and maybe 70 or 80% of those mu receptors are covered with fentanyl. I give them a very tiny dose of buprenorphine, and the buprenorphine just pushes off one of those fentanyls and not all of them. And so the patient doesn't feel perfect, but they don't start vomiting and writhing and sweating and end up in your ICU. So, and this would represent maybe a 1 milligram dose of buprenorphine, or maybe a 0.5 milligram dose. depending on exactly what the patient was looking like. As you can see by the picture to the right, that's person's happy. And you can see that the happy as Mickey Mouse. Everything went great, feeling wonderful.
That's Minnie Mouse.
Yeah, that's Minnie Mouse. I'm sorry. I didn't know. I've mixed up my mouses before.
Your mouses?
My mouses.
Your mice?
My mice. And so the patient experience with microdosing, what is it like? Well, their symptoms improve, but they're not gone. All right. So we still may need these other medications that sometimes we use, like clonidine, like Zofran. And I think that we have to understand that, and we have to prepare them for that it's going to be a day or two of just kind of slowly improving how you feel. But you're not going to be like in the old days where somebody was using heroin, they'd walk out and they just feel fabulous and go right to McDonald's, get a couple of burgers and felt great. It's not like that. Now, how do they do it in other countries? Well, I can tell you in Canada, they tell this patient, you know what, we gave you some buprenorphine. It's okay if you go home and use some of your fentanyl, but use about half or a third as much as before. It'll take the edge off the symptoms and you'll feel fine. And then just keep increasing your buprenorphine like we have said. And that actually works. Okay, that works great. Here, it's this kind of a slippery slope. I have difficulty telling somebody to use it, but if they do, if they figure it out, it doesn't affect your induction. Okay, it just makes them feel a little bit better. So the last thing we're going to talk about today is macro inductions, and again, micro inductions, not a lot of studies. A lot of this is theoretical, and a lot of this has been how people have figured out how to do it, and we all do it a little bit differently. Okay, macro inductions, there's no studies to speak of that are huge or big. And what brings about macro inductions, and I'll step back just a little. A couple of years ago, if you were doing an induction and somebody went into precipitated withdrawal, the theory at the time was that you'd go right to 32 milligrams of buprenorphine. So you'd give them the biggest dose you could give them. And then you'd hope that flooding all of those mu receptors with that buprenorphine might take them out of their symptoms. And I'll tell you, it doesn't work great. And sometimes it does work. And so there are people who still believe that macro inductions, or giving large doses, even in the face of fentanyl, is reasonable. And a macro dose is considered dosing a person more than what it would say in the training for buprenorphine, giving them those doses more than 12 milligrams. And so most people, when they're talking macro inductions, are talking 24 to 32 milligrams and even higher, to give patients enough to cover all the mu receptors, because even at about 12 milligrams, you're covering about 70 to 75% of the mu receptors. Down at about 8, it's a lot closer to 40 or 50, right? So we have to, they're sometimes going to try and cover as many mu receptors as possible. So why would we do a macro dose? Why would we do that? Well, one of the groups that did this study that I'm going to show you, their feeling was that if they got people in the emergency room and they could give them a big enough dose in their time there, it would last long enough that they could actually then get further treatment or get linked up with a physician who did this kind of treatment in the community. And so they were trying to do it for patients who had poor access to care so that they wouldn't leave the ER overdose and have a problem. And so also the feeling was the potency of some of the different drugs, including fentanyl, might make this work better, which again, the microdosing crew would disagree with, okay? And so what is the theory behind all of this? So one of the things is you want to again give them a big enough dose of the buprenorphine that you don't have a lot of available opioid receptors. So you need this large dose, and you also need that large dose to suppress the withdrawal of symptoms from the fentanyl. So I think that when we look at that, they're talking about doing what is called an accelerated induction. They're talking about getting their doses and their blood levels up in 3 or 4 hours to what normally you would be trying to do in 2 or 3 days. And the feeling was by the people who did this little study was that they would be much safer when they left the ER and they went to, when they went and got treatment as an outpatient. And so this study was actually done retrospective chart review, okay? And so they looked at how they were doing patients with high dose buprenorphine in the ER, and they had actually 579 visits for 391 adults, and these are this was in an urban emergency room, okay, in California. And really the purpose of this was to decide how tolerant of these high doses are people. Can we give them these big doses without precipitating withdrawal and causing these patients lots of problems? And so they kind of had these pathways to kind of look and see whether or not it would work. And so these physicians and these APPs were actually trained on how to do these macrodosing protocols. They had 54 clinicians involved, and they were looking at a population that was had a large number of homeless patients, a large psychiatric community. It was mostly men, almost 70%, but it was, almost a third probably was kind of that marginalized community that was homeless and chronic mental health problems. And really what they wanted to decide was, what's the occurrence of precipitated withdrawal when we use macrodosing? Frankly, it would scare me to do this, but this is what they did. And they wanted to know, were there serious events, that the buprenorphine caused? Did these patients get sedated, or did they get apnea or anything, hypoxia? When I guess my first thought it would be the exact opposite. Again, my concern would still be precipitated withdrawal. We know that buprenorphine has a ceiling effect, and so even at 32 milligrams, it is very difficult to make anybody have any sedation, respiratory depression. That typically does not happen. So during these inductions, if you look, 63% of the people had more than 12 milligrams, and almost a quarter received more than 28. So we're talking pretty big doses. And what they found was that, in fact, this buprenorphine at these doses was relatively safe. Nobody had buprenorphine toxicity, which we would not expect because of what buprenorphine is like. But they only had about not even just under 1% of the cases got precipitated withdrawal, which honestly, I think those of us who do micro inductions or do the majority of our patients as micro inductions find this very interesting. And I'll say this now, Dr. Bell and I were at a meeting with 30 addiction doctors, and in the room, 15 of them were still doing macro dosing, and 15 of us were doing all micro dosing because we'd had precipitated withdrawals. I don't know what the answer is here, but clearly in this one study, they actually showed that they could give these patients these bigger doses and not often get precipitated withdrawal. And again, precipitated withdrawal can be very distressing for everybody involved. So there weren't a lot of adverse events, and these patients did well. And really the conclusion of this paper was that, high dose buprenorphine inductions can be safe and well tolerated. And this is really important, especially in these marginalized communities where we're trying to get them a rapid induction so that we can get them somewhere to be taken care of in the next day or two. But they clearly know that this needs to be a bigger study, and they put that in their conclusions, that there needs to be a prospective study. And I would agree. I think, again, I think the take home on this is there are people that believe, high dose macro dosing is going to cause that precipitated withdrawal. And there's many of us who have witnessed this occurring, and there must be something else involved. I don't know why it seems so random, but when it occurs, it can be pretty life-threatening. And so it's important for you to consider that. I think from my standpoint, I think that doing it slower, I don't think is a terrible thing. I think we tend to start very slow, but we tend to increase relatively quickly to get patients asymptomatic. But I really enjoy doing the microdosing. I sleep better. So when we look at macrodosing versus the standard dosing, there's no clinical indication, clear clinical indication for macrodosing, right? They're not going to come out in this paper and say everybody should be macrodosed. But we know that high dose buprenorphine can treat buprenorphine precipitated withdrawal if you go high enough. And the question is, how high is that? And I think so often too, it depends on what's in your community as far as fentanyl, norfentanyl, and the fentanyl analogs. So it can be very different. But they felt it was reasonable to do it in urgent care. And I think that, again, this is something that we're all hoping that there's a lot more studies on. I'm not going to come out to people and say, hey, you should be doing all your patients this way. I think it's something that you really have to think about depending on the drug, the patient, previous experiences, and insurance. Now, contraindications to a macrodose, there is, in my mind, one for sure. And I think that would be pregnancy. We cannot risk causing a precipitated withdrawal in a pregnant lady. And I think microdosing is probably always the best choice in somebody who's pregnant, just because if you do cause a precipitated withdrawal and you have a miscarriage, we're not going to be happy. No one's going to be happy. I think probably as well, probably the geriatric group over 65 or 70. But I really think pregnancy, to me, is probably that biggest contraindication. But other ones have been suggested. But again, these are not studied. So the take-home point, again, it can be done. Rapid inductions with buprenorphine are reasonable in certain situations. Be very careful again, and if you get to a certain level and you get worsening symptoms, you have two choices. One is to wait and let the symptoms slowly resolve, or to go higher and see if a higher dose of buprenorphine is going to resolve the issue. But it's again, this is something we're all hoping will be worked out over the next few years with studies that are coming. So any questions? Again, it's clear as mud when it comes to microdosing, macrodosing, normal dosing. I think in patients who are, I think we always have to think about patients who are typically just taking pills or we're transitioning. I think normal dosing is always going to work great. I think if we have somebody who is at a higher dosing of fentanyl, or if they're on methadone, always we've got to consider whether we want to do a macro dosing or a microdosing. It's patient specific. So
a couple of things, excuse me, I would add is, if you get a urine drug screen and it shows the morphine or it shows the oxy, that doesn't mean that there's not fentanyl there. And I think this is one of those things that people are like, well, I'll just do a regular induction because there's not fentanyl there, because there's heroin there. You can't say that. A lot of it's mixed together. And, there isn't a great in-clinic, well, there's no CLIA waivered in-clinic fentanyl test strip that you can use. There are obviously fentanyl testing you can do, but none of them are CLIA waivered. So that does create an issue in clinics. And so at this point, I think this is why we choose to do them all microinduction, because it's not going to create issues. I don't ever want to just assume that there's no fentanyl and then there it is. And I think if a microinduction doesn't go well and they start going into withdrawal, well, then you can convert that to a macroinduction very easily. Can't convert the other direction, obviously.
Hard to go backwards.
And like we mentioned, the insurance thing, an insurance company might not let you bill 32 milligrams or the amount of buprenorphine needed to do certain macro inductions as well. So,
it's much easier done in an ER where you have control of what you get from the pharmacy, and they're just going to bring it down to you. If you're trying to order it, it can be complicated. So.
Yeah, and I think the final thing I would say is, if you're brand new to this, or if in your clinic you have people brand new to this, or providers, or you're curious as you're nervous about this, or if something happens and a person does go into precipitated withdrawal, please just call us. Our cell phone numbers are there. We can walk you through. I mean, we've walked through a lot of first time inductions over the phone to help with that, or to plan ahead the day before. So please just reach out.
Yeah, there's a question here about, home inductions for patients that show up in the clinic not in withdrawal. Should you do a home induction or in the clinic? And again, to me, it's always the patient. How well do I think this patient can follow the instructions? How much experience do you have with it? Have they been on buprenorphine before and understand how to use it? And of course, what's their drug? Is it fentanyl? Do we know that for sure? If it's pills, and we've seen a lot of people over the years who are taking 6 or 8 or 10, oxy a day. Those, you can comfortably a lot of times do at home. I think if I got somebody who's fentanyl, I probably am going to bring them in and do it in the clinic. But that's just, and I've been doing this, 4, 5, 6 years, I don't know. And I think that it's just still, I like to have my eyes on them in case they're not doing well. Pills and IV are just so different how they act.
I would say the other thing with two other things, I guess, with answering that question is, do they have someone with them to help them? Because these home induction protocols, especially if you're going to try to do a micro induction, home induction, there's a lot of instructions there. And even just like a straightforward, regular, normal induction, as we're calling it, there are instructions. And if they're not feeling well, or they might go home and fall asleep, or if they have access to other substances that they might take because they're not loving it yet. So you do run into that. And then, if they have someone there to help them, that's great. The other caveat with some of this is that you will have patients come in saying, well, I can't go on Suboxone, I use fentanyl. And so there is this thing where patients don't think that they can even be on Suboxone if they've been using fentanyl, because a lot of patients have already used Suboxone on the streets before. They can tell you their dose. They can do all that. And so, they've converted to fentanyl, or fentanyl's been mixed into their supply, and they've tried to use Suboxone and they got horribly ill. They put themselves into precipitated withdrawal. So now they think they can't use Suboxone on fentanyl. So there is education there. No, you just gave yourself too high a dosing. Yes, I know in the past with heroin, this is how you dosed it. Fentanyl's different. We can do this. And that's the patient you're for sure going to want to start with a micro induction, because they're already afraid of it.
Yeah. Remember that the most common size of Suboxone probably in the community is 8 milligram that they buy. And I've had multiple patients on fentanyl who said, I can't take Suboxone. I took 8 milligrams, that just about killed me. And so they caused their own precipitated withdrawal. And so understand that they didn't think, they knew that with heroin, they could take 8 and they would be fine. But with fentanyl, if they take 8, sometimes not so much. So their perception is that it doesn't work. So keep that in mind. All right. Well, any other questions before we let everybody get back to their work day? All right. We're going to let everybody go. Everybody have a good day. Nice to see you, Vanessa. And Nancy and Lisa. I see all these people with their videos on. So, all right. Take care, everybody.